Assalamu alaikum. How are you, everyone? I will share with you my experience in the PACES exam uh, for more benefit to all of you. So, starting by the neurology station, neurology and cardiac station. The case was young male. He was with the affliction deformity, and the examination went smoothly, patient comfortable. He was having features of upper motor neuron lesion. So on examining his gait, it was conclusive for circumduction, along with the hypertonia, hyperreflexia, and the all sensation modalities were normal, entirely normal. So almost patient was with upper motor neuron lesion, mostly suggestive of hemiplegia. So the question was going about the cause of hemiplegia in young patient. Starting by what the case. So you can say hypertonia, hyperreflexia, and weakness due to the spasticity, along with the intact sensation and weakness in the same side. It was left side, the hand, the arm, and the leg. And along with the gait, circumduction gait. So the possible diagnosis here is stroke. The next question, what the most possible cause? Yes, can be infarction or stroke, sorry, either ischemic or hemorrhagic. And the third differential could be multiple sclerosis. Then he asked, the examiner asked about other possible. So you can mention vascular. However, this patient was having scar in his right scalp, maybe related. He pointed to the other colleagues when they examined, but he didn't point with me. He pointed to them. Anyway, the next question was, so what's your differential? And already answered. Then if this patient came to you in this state acutely, what you will do? So you can, I mentioned the type of investigation. However, I said initially, if the patient came in the acute state, I should proceed for CT brain to rule out hemorrhage. Then he asked me, what other investigation you want to do if he came to you in the clinic with the old finding? I said, we have to do, apart from general investigation and baseline basic workup. And he said to me, what workup you want to do? So I said CBC for and coagulation profile for the clotting factor. CBC, you can say for polycythemia or other causes, for example. Other than this, the specific investigation in this patient was for lipid profile, diabetes, hemoglobin A1C, hematuria, and the kidney function test for kidney affection. Then he asked me how to manage this patient. I answered like starting by if the patient came in the acute state, ABCD approach, and assuring that the airway is intact. Then you can go further with the control of comorbidity if the patient is having comorbidities like diabetes, hyperlipidemia. Yes, I forget to say also I mentioned the lipid profile and the investigation, in a specific investigation. Inflammatory markers, if you suspect vasculitis, also was mentioned. Anyway, for the long-term management, control the comorbidity, the hypertension, the diabetes, thyroid, also was mentioned in the specific investigation. Apart from this, I could do MRI to diagnose or to check for the possible finding, along with carotid Doppler and ultrasound Doppler of the carotid. The management, multidisciplinary team, and physiotherapist, and so on. He asked me lastly if this patient is driver a heavy vehicle, should you stop him? I said yes, he should stop driving. He asked me for how long? I said for 5 years. I'm not sure about the duration. Anyway, I mentioned like that. This was for the neurology case. Then moved to the cardiac case. She was a female young. And yeah, there was a sternotomy, mid-sternotomy scar clear. Uh, unfortunately, she was obese. Anyway, he asked me what the finding. I mentioned the flaky first heart sound with normal second heart sound. And along, of course, of the mid-sternotomy scar. The apex beat, I said honestly, I couldn't palpate because of the breast, I mean, and the obesity. And then I said I couldn't even know the character of the apex. He said, okay. Then he asked me about the pulse. Formally, I said the pulse is synchronous, both arms, and normal volume. Then he asked me later, did you notice anything else in the pulse? I said, yes, it was irregularity, mostly AF. Then he asked me what else. I said there is a murmur on the aortic area. He said, what could be? I said, this is could be a functional murmur. He said, any other murmur? I said, no. So he said, he asked me, what's your differential? I said, functioning mitral valve replacement. He said, what do you mean by function? I said, normal functioning. It's not, no murmur there, so it's functioning well. Then he asked about, I said, sorry, I said no stigmata of infective endocarditis. He asked me what is the stigmata of, of infective endocarditis, you know. Then I mentioned to him the Janeway, oslar nodes, and splinter hemorrhage, along with hematuria or immunological phenomena like hematuria or kidney affection. Then he asked me if this patient came to you, what medication you want to start here on? I said anticoagulant. He asked me what anticoagulant you want to. I said it's vitamin K antagonist, warfarin. He said, what about the work? I said, no, can't be. Then he asked another question. How you investigate this patient? I said, starting by basic workup. CBC, he said, what do you expect in the CBC? I said, it might be anemia, hemolysis, I mean. And he said, what type of anemia? I said, hemolytic anemia. He said, what kind of hemolytic anemia? So suppose it's normocytic, normochromic anemia. However, I said it's microcytic, so this was a mistake. Wrong answer from me. Anyway, he asked me what else you would like to find in the CBC. I said leukocytosis to rule out infective endocarditis. Then he asked me what other investigation? I said inflammatory marker, again, to rule out infective endocarditis, ESR, CRP, and specific investigation. He said, what is specific investigation you would like to do? I said, blood culture, to, two blood cultures, 12 hours apart, and ECG and echo. Then he asked me if this patient will follow up with you, what you want to do with her. I said, we'll do serial echo, follow up the function of the replaced valve, any association, any complication, and any other valvular affection, and the function of the heart. And serially, I said echo maybe annual, but she should follow with the cardiologist. Then he asked what, another question, or it was the last question before the time was up. He asked about, let me remember, it was, I guess this was the question about the cardiac case. Yes, the last question, actually it was earlier, but I forgot to mention this question earlier. He asked me, what do you think the causes of diseased or mitral? I said in developing countries, first cause could be rheumatic heart disease. Then he asked what other, so I said could be infective endocarditis, mitral valve prolapse, and the cause of mitral valve prolapse like collagen disease, connective tissue disease. And he asked me, is there any congenital? I said yes, could be congenital also as a cause. I guess this was, or these were the question for the cardiac station. Let's go to the next station. It was communication case and abdominal examination. So the communication was elderly patient, 70 or 65 years. Patient came with high blood pressure, his known hypertension, and he came with low found collapsed by the daughter, and he was talking to the daughter till the hospital, according to the scenario. Then he admitted, started on glyceryl GTN infusion, I mean. Nitroglycerin infusion, I mean. Okay. Then after that, the CT showed that he had ICH, intracranial hemorrhage, and they tried to control the blood pressure by nitroglycerin infusion. However, after sometimes his conscious level dropped more from 10 to 6, and he became unresponsive. They repeated the CT brain, showed IVH, interventricular hemorrhage. So your role in the ward to talk to the daughter, explain the condition, and frankly, talk about the end of life care, as the patient was seen by the neurosurgery team, and they said can't be, and no need or no further management or no further intervention. Okay, so it's clear, like breaking bad news, and to speak about end of life care. Okay, I started. Actually, the daughter was aggressive. I think this was instruction by the examiner to be aggressive, to test how you can control your temper and your anger with the angry patient or angry relative. Anyway, the daughter started aggressive, and I asked her first introduction, and it's next of kin, what do you know about your father condition and what's your expectation? She was so aggressive. She said, my father was okay talking to me. What did you do? Everything was okay. Why he's like that and blah, blah, blah. The expectation, I expect you to tell me what happened, doctor, with him, why he is not talking to him anymore. Okay, so yes, you can. I asked her, you want me to explain? She said, no, doctor, I know everything. Just tell me what happened. Okay, I told her because of the bleeding and we started some medication, but it couldn't control the blood pressure. However, the bleeding extended to another area in the brain. So it was in the brain and extended into the I said into the socket of the brain, or sorry, into the bucket of the brain. Or I cannot remember the exact word. In a way, I didn't mention interventricular hemorrhage, so I mentioned something else. I guess it was like a brain bucket. I think so. Anyway, uh, that's why I recorded this session, because with the time you will forget everything. I tried to record it in order to remember all the details before it will be fly from the mind. Anyway, she said, What are you saying? What do you mean, doctor? I said, this bleeding extended more into a level it can't be even removed. She said, are you sure, doctor? I said, I'm sorry about his suffer. Of course, earlier I was sorry about that. I'm so sorry about the suffer of your father, what happened to him. I'm here to address your concern and so on. I tried to be more calm because three of examiner looking at you how to deal with. Anyway, uh, she said, doctor, what did you do for my father? I said, actually, we did our best. We tried the medication and in the best interest for his condition. However, he didn't respond, and even the bleeding extend more. Then she said, doctor, can you do surgery for him? I said, unfortunately, we had called the surgeon and they reviewed the image, and they said no possible intervention can be offered for him and his condition. She said, so doctor, what you will do? This is the time to talk about what's called end of life care. So I told her, your father already suffered and he's not responsive anymore, and he was seen by group of doctors, and they are uh, skilled professional, and they think that your father will not get benefit from any interventions. So she asked me, what do you mean, doctor? You will not even do anything for my father? I told her, I'm afraid to say no. We will just give him the maximum support he needs in these days. He needs to be free of pain. So we will be sure that pain free, and we'll give him some painkillers, and we'll be sure he is calm and comfortable in the last days in his life. She said, what? You want to leave him die? I said, I'm afraid to say he is already in advanced stage, and we can't do anything else. So apart from this, he had, yeah, it was mentioned also in the scenario earlier that he had chest infection because of aspiration. So I told her even he had chest infection and was started antibiotic. This also make his condition more deteriorated. She said, "What? How this happened?" I said, "Because he lost his awareness. So some of the food particle, went inside his lungs through the windpipes. For this, we started some antibiotics. However, he's not improving, so we will stop everything." She said, "Doctor, what about the feeding?" I said, "Even the feeding, I'm afraid to say, we will just put him on some fluid through his blood channels." I was clear, and she, at the end, accepted. And before the end, I asked her, "Can I ask you some questions?" She said, "Yes, doctor." Started to talk about the advance directive. I asked her if he has any living wish, any document that he wants something, and blah, blah. She said, Doctor, no, nothing. He wasn't. So I said to her, uh, we will do, yes, I offer her some of her family member to come and to share her this moment to support her. If you have any family member need, you can call them to come and to see your father. And from our side, we will try to keep and to let him die in peace the last days in his life, and to keep his dignity without any uh, harm. Then accepted, and I told her, "Do you have any concern?" She said, "No, doctor." I offer her also some spiritual team support, bereavement team to sit with her to give her the maximum support, and also her family, if they need any support, they will be around to support the family and her. I thank her. Then time was up, shifted to the abdominal case. In the abdominal case, patient elderly, little, maybe 50s or 60s. He had a wasting of the hand muscle. It was clear. And also he had the clear laparotomy scar, midline laparotomy scar from the zip sternum down to the umbilicus. So I finished the whole steps of examination and started the questions. So I mentioned the positive finding. I said about twisting, and he asked me what else, what in the tongue, in the abdomen. I said there is mid laboratory scar, and the liver was palpable, 2 fingers below the costal margin, and I I calculated also the liver span, and it was 5 fingers, around 10 centimeters. And I mentioned to the examiner. He said, "What else?" I said, "The spleen. I couldn't feed the spleen." He said, "You could or you couldn't?" I said, "No, I couldn't feed the spleen." And it was good to say that, because unfortunately the scar was for splenectomy, which I realized later on. Anyway, he asked me what else you could find. I said no ascites, no palatable kidneys, and no stigmata of chronic liver disease. Then he asked me, "What do you think this is scar for?" Unfortunately, I correlated to the liver. I don't know how transplant. Anyway, it was the wrong answer. So it was for splenectomy, and yeah, he didn't stress on this point and this wrong answer. Anyway, he moved to the next question. So this patient came to you with abdominal pain. What you should do? I said started by the basic investigation, liver function test, CBC, and inflammatory markers, all hemolysis workup, bilirubin, and LDH, and other labs for INR and clotting factor for the function of the liver, I mean. Then he told me, "What else you do?" I said, "Ultrasound abdomen to confirm the diagnosis." He said, "What diagnosis you suspect? And what differential for abdominal pain in this patient?" I said, it could be uh, it could be a peptic ulcer disease, or could be mesenteric ischemia. He said, "What else?" I said, I don't know what else might be in this patient." Anyway, then we shifted to the other question. He asked me, yeah, what if this patient came to you with hematemesis? I said ABCD approach first of all. Then I could call the gastroenterology for further intervention. Then he asked me what other management, I said, we'll do CBC. If there is anemia, we could start transfusing him blood. Then the time is up. I moved to the next station. It was a long clinical consultation case. I read the scenario. It was about 54 male patient came with a painful ankle swelling. So I guess it could be a charcot joint. I put my differential. I wrote my preparation and my scheme for the history and so on. I put the differential for charcot joint and gouty arthritis and DVT. I went in. It was a patient, 54, and I sat with his daughter. So the surrogate was the daughter, actually, and it wasn't mentioned outside anyway. While taking the history, I found the patient started to have pain. I asked for the scale, the onset, course, duration, progression, and so on. And actually, the pain couple of weeks. I guess it's going with charcot joint. So I immediately jumped to the medical history, any long-lasting disease. And yeah, definitely he was diabetic. And I asked about the medication list. Is he controlled? Is he compliant or not? And so on. And I found he's not compliant to the diet or the exercise. This was the clue in the case that he had poorly controlled diabetes. So I immediately asked about the causes, the diabetic complication. Started by nephropathy, retinopathy, and the neuropathy. The all question related. Then the examination. I asked, can I see the leg? Unfortunately, when I went to see the leg, I found all the examiners standing behind me. So I did the examination. However, I didn't finish the history. Anyway, I said, I could I could take from you history while doing examining the father. Anyway, I started examining the leg itself, the mobility, the passive movement, the active movement, the sensation around. Then I did full neurological examination of the sensation modalities. Examined the fine touch, the pinprick, the vibration, the joint position. Actually, all were lost at the level or at the distribution of gloves in the stocking. Anyway, during asking the history, I asked about the any change in the bowel habit. Yes, he was having change of alternative constipation and diarrhea. So I guess there is gastropathy. And I asked about any surgery. She said he had a heart attack and he did some. So it's clear about diabetes and uncontrolled or poorly controlled diabetes. Anyway, I sit back. Then when I remember the heart, I examine the heart for the possibility of heart failure and so on. The vision, I offer for the visual acuity, it was okay, nothing there. Then I asked the rest of question for system review and the alcohol smoking. He was a smoker and not taking alcohol. And I asked the job. She said he's taxi driver, so I told her to stop driving. And because of the feeling, the loss of the sensation in the feet or the sole. Okay, then also advice about smoking. And then the Yeah, I asked about the stroke or mini stroke and so on. Okay, let's go to the examiner question. He asked me what the finding. I said in the history, blah, 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 poorly controlled diabetes. He's not following with the retinopathy, sorry, with the ophthalmology or nephrology or neurology or the diabetic clinic. Even the hemoglobin A1C was 9 in the last 3 months. And he has this pain for the last couple of weeks and so on. He said, okay, what do you think? I said, this is a case of charcot joint and for possible or further management. He said, what the other differential? I said, DVT, sorry, so gouty arthritis and DVT. He said, DVT. I said, yes, could be because of the asymmetrical swelling of the leg. I could think about it. However, no family, no travel history. He said, okay. Then he asked me what he will do with this patient. I started by basic investigation, CBC, inflammatory markers, rule out stomatitis and other infection. And he asked me, did you do the examination of the power of the legs? I said, I feel the patient is having pain, so I couldn't proceed further with the movement. However, I asked him for the passive movement, but he couldn't move the leg, the foot. So he asked me, did you do the reflex? I said no. However, I should do. Then he asked, did you do abdominal examination? I did. I said, um, actually no. However, also I should do. Then he said, okay, okay. So what's the management plan for this patient? Multidisciplinary team approach, diabetology, and so on. Dietitian also for his diet, he should be on regular exercise, some regime for the diet, and blah blah blah. Then he said, what other management? I said for his food, he should be treated or followed by orthopedic, and he should take rest and also forecast. He said, what scan you can do for the leg? I said, it could be X-ray and might need to do MRI to rule out osteomyelitis. Actually, the time was up. Then I went to the next station. Next station was the communication and the chest. Yes. So the communication was about a young patient diagnosed with inflammatory bowel disease, refused to take the enemas he is embarrassing to do. So the consultant prescribed for him steroid, and he started a steroid for yeah, and he didn't inform him about the possibility and the complication, which is happened to him, a vascular necrosis of the hip, and he came with the avascular necrosis of the hip, and I think I don't know, either underwent the surgery or fixation or sorry, the replacement or not. I'm not sure. Anyway, so the question, sorry, is the history or the paper written there, medical error. So talk about the medical error, and he want to file a complaint. Yes, started by introduction and what you know about your condition, the expectation, and so on. Then I asked him if you want me to explain about your disease. He said, no, no need, doctor. I know everything. Just I want to know what happened to me and why and blah, blah. I said to him, yes, what happened to you? You was prescribed, sorry, you were prescribed by the consultant. He said, no, he wasn't a consultant. I said, okay. Uh, and prescribed steroid for me, and I was refusing to take the enemas. I didn't address why and no, because it was written outside. So I just jumped to the point of steroid, and I didn't argue with him. Yes, immediately I told him we are sorry about that. Actually, we had a mistake and we should apologize for this mistake. You should know everything about any medication and be sure that this is not intentionally. We used to mention all the complication to all our patient. And he asked me, so doctor, what you will do? I said, yes, we had an action. We wrote up a report which called incident report. We raised it to the consultant and we had monthly morbidity meeting to discuss about these and such kind of mistakes. And also we had a meeting with consultant. All this to prevent this mistake from happening again to you or any other patient. Okay, then again, we apologize on behalf of the whole team about this mistake. He said, okay, I want to complain, doctor. I told him, yes, I will guide you. I appreciate your worry, your concern, and so I will guide you to the office, which is called Patient Advice Liaison Services. They will proceed with you and so on. Yeah, supposed to say also that that will not affect you, the management. He said, okay, doctor, what you will do with me? I said to him, we will refer you to the what you will do regarding the steroid. I mean, I told him steroids shouldn't stop abruptly. We should taper down or reduce the dose. Anyway, we will refer you to the gut doctor and the clinical pharmacists. They will give you the alternative, and they will also they will tell you how to do the steroid in another meeting. He said, okay, doctor. So, uh, doctor, what I will do with my job? I said to him, yeah, we are sorry about that. We will provide you with a report, and we will give you a sick leave, and we will arrange with our occupational team to help you in your job. Okay, I'm not sure about driving, but suppose also to ask about driving because he has some problem in the knees. Anyway, I didn't ask. Okay, then any other concern? No, doctor, thank you. I found still the time is uh, available to discuss something else. I asked him again, any other concern? He said, no, doctor, thank you. Okay, so I found I should mention something because it's still 2 minutes. So I raised the issue of red flags and safety netting. I told him, yes, please, whenever you are back, and I will give you some instruction. He said, what, doctor? What do you mean by this? I said, when you are back, and I know you know about the disease, but there is some complication might happen in your condition, inflammatory bowel disease. He said, what, doctor, you mean? I said, I sometimes if you feel like you having passed blood or more than usual blood in the back passage, sorry for this word, and if you have loss of weight or you have lumps or bumps, night sweat, night body temperature, uh, don't hesitate to call our department or to come immediately to the emergency. These things or these alarms, these finding might me guide to something maybe serious. Okay, he said, okay, doctor. Okay, any other concern? No, doctor, thank you. Again, I found still time, so I told him, I will give you the hospital contact number about our clinic. If you feel any inquiry, you can call us. And that's it. Okay, well, done with the communication. So move to the chest. The chest was patient, underweight, cachectic, sleeping, and yeah, he looks like a toxic patient, or not toxic, I mean sick patient. Okay. The finding was conclusive for wheezes all over, and there were palmar erythema, but no clubbing. Some cyanosis. Anyway, I examined the patient, and I appreciated the wheezes, respiratory and expiratory, and uh, some increase in the diameter, anti-diameter change, sorry, anti-diameter, anterior posterior diameter of the chest. Means it's mostly a patient is COPD. Okay. Also, patient was coughing. Okay. The examiner asked me what the finding there. I said about the limited expansion and the about the expansion and limited expansion, wheezes all over, scattered. And he asked me, what do you think? Then he asked me, what other finding? What about his weight? I said, yeah, he looks underweight. Okay, he said, what do you think about the case? I said, yeah, the patient is having scattered wheezes and increased anterior diameter and tracheal tug. And yeah, he said, so what's your possible or differential? I said, it's almost obstructive disease, obstructive lung disease. He said, what's your differential? I said, oh, COPD. It could be, he said, what else? I said, could be bronchiectasis. He said, okay, so what do you think about his weight? I said, yeah, he's underweight and it might be bronchiectasis. By the way, there was this mid laboratory scar in the abdomen. So I said, yeah, maybe irrelevant or maybe relevant to the case. So the questions was, what would you do with this patient? I said, first of all, I will start, I will do ABG, bedside oximetry and pulmonary function test. He said, well, what you could find in the pulmonary function? I said, could be, it would be obstructive, but he said, what do you mean by obstructive? I said, forced expiratory volume 1 over the forced volume capacity more than, sorry, less than 70. He said, what do you mean? I said, the forced expiratory 1, expiratory volume 1 will be low compared to the forced volume capacity, which is normal. He said, okay, so what you do with the patient? I said, uh, basic investigation, CBC, and to rule out infection, leukocytosis, and the inflammatory markers for infection. He said, what do you think this patient's criteria for infection? I said, it might be with cough. Patient might present with cough. And he said, what else? I said, yeah, it might be lymphadenopathy. However, I didn't do examination of the lymphadenopathy. I missed the neck lymph node. He said, what else? I said, fever. He said, okay, what medication you could give to this patient? I said, starting by, sorry, yeah, how to manage? I started by multidisciplinary, the pulmonologist and respiratory therapist, rehabilitation. He said, what else? I said, he should stop, yeah, education counseling. And he told me what. I said, yeah, he should stop smoking, yes. He asked me what other medication you can give this patient. I said short-acting beta agonist, short-acting muscarinic antagonist. Then he asked me what else you can offer to this patient medication. I said, yeah, if the patient is having asthma feature, I could start him on inhaled corticosteroid. He said, what other medication you could start? I said, we can start him on long-acting beta agonist and long-acting muscarinic antagonist. Yeah, the time was up. Then moved to the last station, which is long clinical consultation. Young, 35, came with abdominal pain for 2 days. Temperature outside was 39 in the paper, and blood pressure 100 over 70, pulse 100. So speak with the sister. Okay, I went in. The history was started by the onset, course, duration, the nature of the pain, the site of the pain, and the previous attack. Yes, he was having previous attack. So it was guided mostly to something which we know about, recurrent abdominal pain. Anyway, and so what other GI symptoms? Mouth ulcers, difficult swallowing, diarrhea, or sorry, any change bowel habit, or any change uh, in the water work. Nothing. So I asked about any long-lasting disease. No, he wasn't. I guess there is possibility of FMF. I confirmed when I asked about any family history, and he said, or she, the sister, she said yes, the father had a kidney problem and he was in failure. Then I realized it's yeah, inherited condition. So FMF now on the top. Actually, I later on I remember to ask about the father. Yes, I asked the sister, how's your father now? She said yes, he did. So I just been sorry for that. I'm sorry for your loss and my condolences and so on. Anyway, no, I asked also for travel history to rule out any travel history to rule out any yes PE. Yeah, I remember diarrhea. She mentioned diarrhea, and I asked later on what the diarrhea about, the smelly or the smell or the amount, the criteria, the frequency. Anyway, it was just to screen because it was positive. Then I asked about chest pain, and when I asked chest pain or awareness of heartbeat, yes, she said yes when he's febrile. Then about the chest pain, she said no, doctor. Then the examiner shouted at her. He said, "What? There is chest pain." Okay, yeah. And I said, okay, so mostly it's like in my. I mean, I didn't say that anyway. I thought about yes, serositis and pleurisy. Then I offered to examine the patient. I asked about also the job, smoking, alcohol, and yeah, I think he was accountant or something. And it's anyway, it was nothing related. I asked also about any surgery before, just in case of appendicitis. Okay, then I offered to examine the patient. They told me yes, you can proceed. I guess patient was surrogate, so nothing was there. Started by general look. He was okay. Inspection, the abdomen, nothing there. I feel the liver, the deep palpation, the kidney, all the steps of abdomen examination. Then lymph node, axillary lymph node, nothing also was there. At the back, the heart. Sorry, before examining the heart, the legs, nothing was there. Actually, clear he is surrogate. Then, yeah, I missed also the medication list. Medication list was about where some medication analgesic like painkiller, diclofenac, and what some other paracetamol and so on. So I give her immediately advice about the paracetamol. Sorry, the Voltaren. It's not recommended to take it without medical advice. It might lead to some kidney problem like the father. especially it might be complicated already. Anyway, I finished examination. Then when I remember the chest pain, uh, I asked again to do examination for the patient. He accepted. He said, yes, yes, you can. And also, every time you go to the patient, they are coming with you, so you will be more stressed. Then I went to examine again the chest, the back, inspection, palpation, everywhere, everything about the expansion and so on. Nothing was there, definitely. Then 2 minutes left. The concern, what he has, why my father died, and any medication, doctor? Yes, I said yes, there is medication. What he has, condition called familial Mediterranean fever. It's running in families, and any cure. Yeah, there is chance for some medication called. She asked me what the medication, doctor. I said it's called colchicine. Okay, then the examiner question. He said, what do you think about the case? I said, positive finding 1, 2, 3, started from the history, from the finding for the family history, the nature of the pain, and so on, the recurrence, and the abdominal symptoms. He said, so what do you think about the diagnosis? I said, it's familial Mediterranean fever. He said, what other differential? I put acute intermittent porphyria, but I said to him, against that, there is no neurological symptoms or psychological symptoms. Then he asked about the other differential. I said acute, yeah, angioedema, and there is no signs of lip swelling. And I was asked initially about the next lip swelling. Then I asked about he asked me about other differential. I said chronic pancreatitis and DKA. However, the patient is not diabetic. Okay. The next question, what do you do? Investigation, I said CBC, inflammatory marker for infection, and rule out stool analysis to rule out any GI gastroenteritis and so on. He asked, what else you want to do? I said specific investigation, genetic testing to confirm the diagnosis. He said, what about the chest pain here? I said, it's sinusitis. He asked me what medication you can offer to this patient. I said colchicine. He said, what the mechanism of action of colchicine? I said, I remember something about the mitosis and so on. He said, what the relation? I said, I don't remember, but just I read that about it. Okay, then he asked about the further condition, why I said, yes, it might be amyloidosis or drug induced, so he shouldn't take this medication by unless by medical advice. Then I guess this was how the management plan, the investigation. Yes, I guess this was the last long clinical consultation case. Hopefully, I could benefit. I did this record to just for the benefit of all of you, in order not to forget the question, because with the time, yeah, the question and might be forgotten. That's why I recorded it instantly. Hopefully, I will pass, as well as all of you, all the pass and success, all of you. Thank you, everyone, for the listening, and good luck in your exam. Assalamu alaikum wa rahmatullahi wa barakatuh.